Hi, good afternoon, everyone. My name is Nandong. Today I'm doing the oral presentation for the week 6 of signature assessment for the SOAP note. I'm currently doing my clinical rotation at Dr. Ramin Chopra. It's a pediatric specialty clinic located in Garden Road, California. Today I will be presenting the case of JM, who is an 18 years old Hispanic female present with the diarrhea and abdominal cramping. This case was memorable to me because it highlighted the importance of distinguish between viral and bacterial cause of gastroenteritis, also applying evidence-based care for a self-limiting illness, and incorporating a holistic patient-centered approach. It was particularly memorable because she was actually vomiting in the clinic lobby, which remind me to stay calm, provide immediate support to her, and ensure her comfortable while maintaining a professional approach to care. Subjective information is a JM present and accompanied to the clinic with complaint of diarrhea and diffuse cramping abdominal pain for 2 days. She report having 6 to 8 watery stool per day with pain the rate 6 out of 10, worsening before bowel movement and slightly relief after work. Symptoms began suddenly after eating food from a street vendor last night. She also reported nausea and mild fatigue, but denied blood in the stool, fever, or recent antibiotic use. She has dry oral rehydrations and loperamide with minimal relief. Her past medical history is unremarkable. She has no chronic illness, no hospitalizations or surgeries. Family history including her father with type 2 diabetes and hypertension, her mother with hypertension and GERD. For social history, she is sexually active with condom use, drink alcohol occasionally on weekends. Her last menstrual period was 3 weeks ago, regular period. And she has no use of tobacco or drug use, no smoking. She drink 1 to 2 cup coffee daily. On review of the system, she's positive for mild fatigue, nausea and vomiting, and also diarrhea, but negative for fever, chest pain, shortness of breath, dizziness, or rash. For objective information I have, all vital signs are within normal limit. On physical exam, she's appear alert but mildly fatigued and in mild distress after vomiting at the clinic lobby. Cardiovascular and respiratory exam were also normal. Gastrointestinal exam review hyperactive bowel cells and mild diffuse tenderness without guarding or rebel. Neurological and skin exam was also unremarkable. A urine analysis was performed in the clinic to rule out any possible pregnancy. For the assessment I have, my differential diagnosis including first one will be acute viral gastroenteritis. This is a most likely diagnosis because she appear with sudden onset watery diarrhea, also cramping abdominal pain and nausea, and the absence of fever or blood in the stool. According to Patel, 2025, the patient present is more consistently with acute viral gastroenteritis. A second different diagnosis that I have will be bacterial intestinal infection. This is less likely diagnosis because she doesn't have any systemic symptoms such as fever or bloody in the stool or any inflammatory features. So that's not that has to be ruled out for bacterial intestinal infection diagnosis. And the third different diagnosis that I have will be bacterial foodborne intoxications. This is less likely a diagnosis, although related to the food exposure that she has. She ate something from the street last night, but the symptom pattern and the durations are not typical of the toxin-mediated illness, which usually has a rapid onset and resolve within 28 to 48 hours. After evaluating the presentations and consultation evidence-based guidelines, I also have the final diagnosis, which is the viral intestinal infections unspecified with the ICD code of 808.4. The plan I have, diagnostic including no immediate stool testing was indicated at this time, but electrolyte would be monitored if symptom worsening. For the therapeutic, I would recommend her to have oral rehydration therapy, continue loperamide as needed, may consider ondansetron 4 mg, PO/BRN for nausea and vomiting as well. Patient educations I would have increase fluid intake and rest, encourage plant diets as tolerated, including avoid diarrhea, caffeine, and fatty or spicy food, practice hand hygiene and avoid food preparation for others people, return to care if the blood in the stool, fevers or worsening abdominal pain or any signs of dehydration. Follow-up, return in 3 days if no improvement, emergency precaution for severe dehydration, persistent vomiting, or high fevers. For evidence-based practice, the plan aligned with guidelines from the Infectious Disease Society of America. Antibiotic and extensive diagnostic were not indicated due to the mild, self-limiting nature of viral gastroenteritis. Alternatives such as the antibiotic or stool culture were considered but unnecessary at this time. For the holistic approach in caring science, holistic care was provided by addressing not only physical symptoms but also the emotional, social, and cultural needs. Collaborations were emphasized by involving the patient in her care plan, discussion hydration strategy, dietary adjustment based on her culture, and symptom management. Cultural dietary preferences were also respected, and educations were tailored to ensure understanding and adherence to the medication treatment. Gene Washington care process were also applied through the compassion, presence, and creating a supportive environment. For example, I provide a reassurance and comfort after she vomiting in the clinic, actively listen to her concerns, and involve her in any decision making. Although she was unaccompanied, collaborations could be further extended by involving a family member at home to assist with any monitoring and support her. Coordinations with nurses and pharmacists could also reinforce the education and improve for her outcome. This case reinforced the importance of a holistic, evidence-based approach, emphasizing supportive care, patient education, and cultural sensitivities. It also highlights the need for critical thinking in differentiating viral versus bacterial cause of gastroenteritis, and the value of remaining calm and compassionate during unexpected events such as the patient vomiting in the clinic. Thank you.